So today, for medicine point of view, we'll see one high important MCQ, which is most commonly asked with respect to CNS in case of medicine. Okay. First question: a 45-year-old patient came with sudden onset weakness of the limbs, and since 2 hours, a NCCT head was done, which is given below. His BP is 200/100 mm mercury. What to do next? And they have given you one CT finding of that patient. Options are: A, go for thrombolysis with IV alteplase as it is within window period. Option B, control BP first by giving labetalol and then go for thrombolysis. Option C, don't thrombolyze the patient as the CT scan shows bleed. Option D, try for mechanical thrombectomy in this patient. So basically, if you see this question, what all they are trying to ask? They have given you one clear-cut history of a patient with stroke. How are you going to manage stroke? Very important thing, both practical as well as INI-CET point of view. So if you see here, first you should know what is the window period for stroke. Next, what you should know is BP is 200/100. So you should know the BP control in case of stroke. And next, if you see the options, thrombolysis, then you should go for thrombolysis. Indications of thrombolysis you should know. And within what window period you can go for thrombolysis, and what are all the other options available other than thrombolysis. If the window period is excess, what more options are also available? That point also you should know. Next, they are telling if the CT scan is showing bleed. So that means interpretation of CT scan in case of stroke patient. So that also you should be knowing. And the last option is telling mechanical thrombectomy in this patient. So what are the indications for mechanical thrombectomy in this patient? All these, if you know as a whole, you will be able to answer this clinically high oriented question. Okay. So first, let's see how to interpret a CT scan in case of stroke. Basics, what basic you should know to interpret a CT scan in case of stroke. Yeah. So first question, a patient coming with stroke features, NCCT head should be done immediately. That everyone knows. But what is the time cutoff within which you should get NCCT done at any cost for any patient with stroke? It is, can anyone guess? It's nothing but 20 minutes of arrival. Within 20 minutes of arrival, you should get NCCT head of the patient in case of a stroke. Okay. Why are we getting NCCT head of in a patient with stroke? It is not that we are going to diagnose what is the ischemic stroke, what level of ischemia is going on, what artery is blocked. No. This NCCT head is done only to rule out hemorrhage. Okay. If the patient has any signs of bleed, like intracerebral hemorrhage, then we can see easily NCCT head as a hyperdense lesion. Whitish areas will be seen in CT, which suggestive of bleed. So if you say in this picture, right side if you see, it consists of a whitish area surrounded by a grayish zone. Can you see that? So this whitish areas represents the bleed. Okay. And the surrounding, if you see, there is a grayish zone around it, which means some fluid. Gray zone means fluid. So some edema is surrounding the bleed. This is a characteristic picture you never forget in case of a intracerebral hemorrhage CT scan. Okay. Yeah, see this. Whitish areas representing hemorrhage and edema. Okay. Next, same see the CT scan in the left part. Here if you see, it's dark gray, meaning if some tissue is getting infarcted, necrosed, it will appear less hypointense in CT scan. So those hypodense areas in CT scan, we call them as infarct. Okay. So mostly you can never see infarct within 20 minutes of arrival in case of a stroke patient. Okay. They're just doing the CT scan only to rule out hemorrhage. Okay. Next, if you see, infarct might not be visible always. Okay. This also you should know. So when you compare to the question given in the CT scan given in the question, what is happening in the CT scan given in the question? There is no signs of any bleed. So the CT scan given in the question is that of a ischemic. Okay. Yes. Now ischemic stroke management, how are you going to do? If it is a hemorrhagic stroke management, it is entirely different. Okay. Management of ischemic. First, if you see, the most important management in emergency in case of a stroke patient is airway, breathing, circulation. Okay. Airway. Why do you want to secure the airway? In stroke, mostly the patient's sensorium will be altered. If it's a cortical stroke, okay, the patient might get seizures at any time. So it's very important to secure the airway in case of a stroke. Next, breathing. Breathing, when breathing comes major importance in case of stroke. In case of, like in stroke, when the patient becomes altered, if the patient vomits or something, that will get aspirated easily. Okay, so the patient might have a component of aspiration pneumonitis also. So if the patient has aspirated enough to cause severe type 1 respiratory failure, hypoxia, in such cases, you should be giving oxygen for the patient first by face mask, non-rebreathable mask, NRBM. If that is not also possible, the patient is gasping, then you should be going for intubation. Breathing becomes an integral component of your management. Next, if you see, circulation. Circulation is also important in case of stroke. That's what we are going to see now. So the BP control in case of ischemic stroke. What is the cutoff? And also, what are you going to see in emergency? BP as well as random blood glucose, sugar. All these things you should be checking within 10-15 minutes, and you should send the patient to CT scan. Okay, within 20 minutes of arrival, all these should be done and CT scan should be performed, and you should have ruled out intracerebral hemorrhage by the 20th minute. Okay. Yeah. Next, if you see, next let's see the management, ischemic stroke management as well as hemorrhagic stroke. So if it is ischemic stroke, you should have an idea of time since symptom onset. Okay, that will guide your management in ischemic stroke. If it is hemorrhagic stroke, whatever may be the time since onset, your management remains the same. Okay, yeah. So now we will see the dextrose control in case of a patient with ischemic stroke. Why is the dextrose control that important in case of ischemic stroke? First is hypoglycemia as well as hyperglycemia can aggravate this infarct extension. How? See, if glucose supply is getting less to the tissues, then automatically that infarct region will get enlarging. More tissues at the region of infarct, which we call as penumbra, which are salvageable tissues. If they get low glucose, their metabolism is already low because of the low blood supply, and combined with low glucose will make them more prone for more injury, more infarct, and infarct expansion. So hypoglycemia should be taken as an emergency in these patients and should be treated. Next, hyperglycemia. 140 to 180 should be your target blood glucose. If it is more than 180, then that means that Even hyperglycemia can cause dysglycation in products, free radical production. All these things can also aggravate the infarct expansion. So only we treat hypo as well as hyperglycemia as an emergency in case of an ischemic stroke patient. Okay, so this is the need for you to know the cutoffs of hypo as well as hyperglycemia and how are you going to treat. Okay, yeah. Next, let's see the BP control. So BP control, if you see, first in case of stroke, you should be planning whether the patient is eligible for thrombolysis or not. If the patient has come to you within 4.5 hours, then that means he is eligible for thrombolysis. If he is eligible for thrombolysis, your BP control should be aggressive, meaning BP should be less than 185/110. It's very important. This cutoff is okay. Your BP control should be there if the BP goes above 180/110. You can give labetalol, which is an alpha plus beta blocker, which is used in hypertensive emergencies as well as urgencies. So labetalol becomes your drug of choice. Treat the hypertension there. Bring the BP below 185/110 if the patient is thrombolysis eligible. Okay. Or you can give other drugs like calcium channel blockers, which are known as nicardipine, hypertensive emergency drugs. Yeah. So goal should be BP less than 180/110. Next, if the patient is thrombolysis not eligible, most of the cases we treat like this only. They will come above, out of side the window period. So there, your BP control can be liberal. Like your BP control can be kept less than 220/120. Because see, some major vessel in the supplying the cerebral cortex or subcortex is blocked. So only if the BP compensates and increase to some extent, it can pass above the clot and it can perfuse the tissues. So hypertension is actually manifested even in normal individuals in case of stroke patients. To maintain the cerebral perfusion, your BP must increase. So only, but it shouldn't increase more than 180/110 if you are thrombolysing a patient, because if you are thrombolysing a patient and if the BP is increased, means that can lead to your alteplase or etelplase, your thrombolysis drugs plus hypertension can cause bleed in the patient. So only we are giving aggressive BP control in case of those patients who are eligible for thrombolysis, and the cutoff is 183/110. Next, thrombolysis not eligible, we are liberally treating less than 220/120. This is your BP in case of kidney stroke. Next, so in our patient, let's see what is happening. So first, a patient has come to you with ischemic stroke. Now, how are you going to manage? First, time since stroke onset you are going to see. If the time is less than 4.5 hours, then he is within the window period. If he is more than 4.5 to 24 hours, or if he is more than 24 hours, three chances are possible. If he is less than 4.5 hours, then he is within window period. Thrombolysis is indicated in these patients. Okay, so whether indicated or not, you should have those set of indications as well as contraindications. You should go and see whether they are indicated or not. Okay, so you should know the indications as well as contraindications for this. So if it's indicated, you can go for IV alteplase. This is the drug of choice for thrombolysis in case of ischemic stroke, which is a recombinant tissue plasminogen activator. Okay, yes. What if the patient is within the window period, but he is not eligible for thrombolysis? what you can do. That becomes your next question. So, if he has any contraindications for thrombolysis, then you can go for CT angiography. Okay, CT contrast given angiography you should see, and if possible, you can do mechanical thrombectomy in these patients. In CT angiography, you are going to localize where is the clot, and through guide wire and interventional procedures, you can suck out the clot. Okay, this is mechanical thrombectomy. Okay, only in those patients who are not eligible for thrombolysis within the window period, you can go for mechanical thrombectomy. Okay, so this is for the patients who come within window period. What if the patient is between 4.5 to 24 hours? There, you can go for mechanical thrombectomy directly. Only option possible in this stage is mechanical thrombectomy. If he is eligible for it, then you can go do mechanical thrombectomy, or if he is not eligible for it, then only option is your antithrombotics like ecospirin or clopidogrel or pravastatin. All these you can give. If the patient is more than 24 hours time since onset, then only option left with you is antithrombotic agents. This is a complicated protocol. I made it simplified for you. This is how you should approach a patient with ischemic stroke. Okay, so you should apply the approach the patient with ischemic stroke. Okay, so next, but you might be confused that what may be the indications and contraindications and how to give this thrombolysis agents. Next, we will learn how to give these things. I told IV alteplase, which is a recombinant tissue plasminogen activator, is a drug of choice. Activates plasmin, so plasmin will cut off all the fibrin threads, thus it will lyse the clot. Okay, yeah. So how to give this alteplase? First, you should give 10% as a IV bolus. Okay, and remaining 90% you should be giving it as an infusion, which will be going for 1 hour. This should be done in a center where neuro ICU is available. Okay. Next, what are the indications of thrombolysis? Interesting indication is age should be more than 18 years. You can't risk to thrombolyze any child less than 18 years. Young onset stroke is also common. So many causes are there, but still you should not go for thrombolysis in young onset stroke. Okay, only age more than 18 years. First indication. Next, time since onset, as we have discussed, if it is, it should be less than 4.5 hours, the window period for stroke. And BP should be less than 180/100 as we have discussed. Okay, by giving labetalol, we can control it. Less than 180/100 is eligible for thrombolysis. Then, clinical diagnosis of ischemic stroke. Ischemic stroke is there, or CT guided diagnosis also you can do, ruling out hemorrhage. These are the easy indications which we have learned from these approaches. Okay, what are the contraindications? How to remember it easily? Let's take some cartoons for it. First, see, in brain. Okay, in brain, if you see prior history of any hemorrhagic stroke, okay, or subarachnoid hemorrhage. Okay, if the patient has had hemorrhage, the two within the brain, subarachnoid hemorrhage, extradural hemorrhage, intracerebral hemorrhage, in his life, okay, whenever it is, then he becomes an absolute contraindication for thrombolysis. You should never thrombolyze the patient. Okay, that becomes your first contraindication. Or any head injury. Okay, any head injury in the last 3 months, that also becomes a contraindication. Next, ischemic stroke. Oh, it should be in the last 3 months. If there is any ischemic stroke, then it becomes a contraindication. Okay. Next, any active abdominal bleeding, GI bleeding, like bleeding peptic ulcer melena ki history, all these becomes a contraindication for thrombolysis, and this active peptic ulcer bleeding should be less than 21 days. And also, any patient who have undergone a surgery in the last 21 days, that also becomes a contraindication. Then, any person who had any active malignancies of GI tract active malignancies are there. Then if you give thrombolytic agents, that will continue to bleed like anything. GI bleeding will start up. So you should never give in such patients. Then active infective endocarditis. This many of them don't know. It's a high yield point also, because in active infective endocarditis, why you should not give thrombolysis? Just think, in infective endocarditis, what is happening is there is infection in the endocardium of the heart valves. So there are vegetation starts to form on the valves as well as the endocardium of the heart. These vegetations can get detached. Okay, these vegetations can get detached, and these vegetations can also embolize the brain, resulting in embolic strokes. So, in such patients, if you give thrombolytic agents, infection combined with the bleeding agent will drastically bleed. Okay, so it becomes an absolute contraindication. Next, so all these are contraindications for thrombolysis. Indications, we saw 4 small and easy indications to learn, and contraindications are very important in respect to health. Okay, yeah. Next, if you see, any aortic dissection becomes also the contraindication. Okay, so thus we learned the indications and contraindications of thrombolysis, approach to a patient with stroke, how to approach the patient with stroke. Next, BP control in case of ischemic stroke, and how to see a CT in case of a stroke, and how to handle ABC, airway breathing circulation, BP as well as dextrose control. Okay, yeah. So the answer will be, for this patient, he has come within the window period, so he is eligible for thrombolysis. He is an ischemic stroke patient. Yes. He has come within window period. Yes. So he is eligible for thrombolysis. Yes. But still, BP is more than 180 by 110. So first, you should go for control of BP in this patient. Okay. Then you should start giving thrombolysis. So option will be B. Control BP first by giving labetalol, then go for thrombolysis. That's it for the day. Okay.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.